Good morning to all. Today's topic is based on interactive session on case-based approach. So coming to the details of periodontal case sheet recording. Learning outcomes are correlate the given findings and diagnose a case applying 2017 period classification system. Compare gingivitis on intact periodontium and reduced periodontium. Differentiate periodontal health and gingivitis. Select the appropriate mechanical plaque control aid for given patient's clinical situation and identify the chemical plaque control agent and its active ingredient and suggest its clinical use. Coming to the introduction, case history, a planned professional conversation which enables patient to communicate his or her symptoms and explains it to the patient, to the clinician, and recorded in the patient's own words as to obtain an insight into the nature of the patient's illness and his or her attitude to them. So it starts with taking the chief complaint and coming to the subjective symptoms, and on examination we are able to obtain objective signs, and by assessing all these facts we are coming to the diagnosis and then coming to the treatment plan. So to the patient you have to introduce yourself, so you have to be a good listener to the patient and allow the patient to express themselves, and you should be trustworthy and ask everything about the medical conditions and write only the pathology. So coming to the patient's demographic details, the details to be noted are name, age, sex, address, occupation, and case number. Under name, it should be recorded with an initials and surname for the identification of the patient and for record and recall purpose and for communication. So it will be a psychological beneficial effect also. So age, under age, so it will be different for infants and children, and also with the puberty stage people, and also with the grown up people to differentiate with the aggressive and chronic in nature. So infants usually with the eruption gingivitis and acute herpetic gingivitis stomatitis will be common, and for the age of like 11 to 17 years puberty gingival and pericoronitis can be seen. And also the gender should be noted that some of the diseases will be different in females and males. At females, puberty gingivitis, pregnancy gingivitis, and menopausal gingival stomatitis. And in males, smoking patients will be more, and which prone to develop periodontitis in chronic smokers. An address is important for the communication with the patient and to rule out endemic diseases like fluorosis. And for occupational type, that is for acid fume works, occupational habits like holding nails by anterior teeth in carpenters, shoemakers. So these all will lead to notching of incised ledges of maxillary incisors, and patient with high psychological stress would be with the bruxism habit. And case sheet number for easy retrieval of case sheet and for statistical analysis in hospital record. Coming to the chief complaint, the presenting problem of the patient has to be recorded in the patient's own words in 1 to 2 sentences, obtained by asking the patient to describe the problem for which help is being sought for reason, followed by the chronological time period for which the problem exists. For example, so if the patient is having complaint with bleeding gums, so patient complains of bleeding gums in the lower, the region should be there. Then with the duration you have to write down. So this in perio usually the complaints can be bleeding gums, pain, swelling, mobile tooth, sensitivity due to root exposure, food lodgement, aesthetic requirement. So writing chief complaint, it should be on patient on words, and also it should be perio complaint. So something related to perio. If you're writing under perio case sheet, it should be like one of this reasons, or it can be if the patient just wants to come for routine cleanup also, you can write that they came for routine scale cleaning of the teeth. Okay, so coming to the history of presenting illness or elaboration of chief complaint. So first one, there is a most important chief complaint, there is a pain and swelling. So under pain and swelling you have to note down mode of onset, duration, type of pain, radiation or localization of the pain, severity, aggravating and relieving factors, and whether the patient has taken any medication or has consulted a doctor. The details should be noted down. And if there is pain or swelling, you have to rule it out whether it's gingival abscess, that is the acute one, and then periodontal abscess or periapical abscess. So when you are differentiating with the gingival abscess, it is more associated with the cervical region, more towards the cervical gingiva, and with the periodontal abscess and periapical abscess, it will be more dull, constant, less severe localized and patient usually can locate the offending tooth. So it will be associated with the movement or percussion is not as severe as with the pulpal disease, and mostly it is towards the lateral aspect of root. And then periapical abscess, that is will be the pain will be more severe, throbbing, lasts for long, deep, unable to locate the offending tooth, and it will be more severe than periodontal abscess, and usually the tooth will always will be associated with caries. The next complaint would be bleeding gums. So when the lesion was first observed, time of onset, spontaneity of bleeding, and mode of development, du- like during brushing or while eating, and symptoms associated with menstrual cycle. So what treatment has been done before, and duration of bleeding, and manner of stopping. And the patient is using mouth rinsing or mouth washes to stop the bleeding. So it has to be noted. Coming to the medical history, which is more important, that is systemic disease or conditions or behavioral factors may play in the course of periodontal disease. So, which aids in diagnosing oral manifestation of systemic disease and detecting a systemic condition that might be affecting the periodontal disease response to local factors. Diagnosis diseases that require special precaution or modification in the treatment procedures. So coming to the details of medical problems, you should ask for medical problems like cardiovascular, hematological, endocrine, etc. So if there is any familial history regarding diabetes, bleeding disorder should be noted down, and also female-related hormonal disturbances can be seen. Then associated gingivitis can be seen. And so that also should be noted. So if there is anything, that nature and duration of the problem and therapy should be noted, and if there is any incidence of the diseases, then details of hospitalization and operation should be noted, and the medications, dosage and duration, hormone supplements if they are taking, or anticoagulants, oral contraceptive pills, this all might affect on the gingival findings, so it should be noted. Then history of drug allergy, dental materials, hypersensitivity should also be collected. So coming to the relevant dental history, so dental history should be noted. So it might get effect on periodontics, that is from different departments. It is can be from endodontics, oral surgery, orthodontics, or prosthodontics. So restorative department, it is usually that is a class one overfilled traumatic occlusion might affect on the periodontium, and also overhanging margins might cause gingival irritation and inflammation, and overfilled root canals might lead to periapical irritation also. So in oral surgery, that is during extraction, adjacent teeth may laxate due to injurious forces and may lead to vertical bone loss, intrabony defect for the adjacent teeth. And with the orthodontics, excess forces usually lead to hyalinization and alveolar bone destruction. And orthodontic brackets, which get impinging to the gingiva, might cause gingivitis, orthodontic induced gingivitis, and fruit retention due to appliance may lead to gingivitis in patients with fixed orthodontic appliance therapy. In prosthodontics, that is acrylic allergy may lead to gingivitis and stomatitis, and same thing for lodgement under bridge lead to gingivitis. If bony spicules are present, so it might lead to denture sores. Oral hygiene habits to be noted, that is, toothbrushing frequency should be noted. Method of brushing, whether it is horizontal or vertical. So, usually, this horizontal type of mode of brushing usually results with cervical abrasion, and duration also is very important. And type of toothbrush, whether it's soft or hard, usually for after flap surgery and all, usually recommend soft brushes for cleaning, and then for the normal routine patient we recommend medium toothbrushes. The type of dentifrices to be noted, powder or paste, because powder will have more abrasive agent, so will have more chance for sensitivity. Other aids such as mouthwashes, finger massage, interdental stimulation, water irrigation, dental flow should be noted. Coming to the oral destructive habits, they are also important while taking the case history. That is, with the bruxism, and with unilateral chewing, mouth breathing, tobacco smoking, nail biting, or foreign objects disorder somehow will affect on periodontium, will affect the health of periodontium. Coming to the clinical examination can be divided into general examination and extraoral general examination. Under that, extraoral and intraoral. And intraoral can be divided into soft tissue and hard tissue. So coming to the general examination, that is same as that of the other departments. That is, examination should commence when the patient enters the dental office. The physical condition should be noted. Shortness of breath after mild exertion could be an indication of cardiac or lung disease. And an awkward gait must be the result of degenerative joint disease, a neuro nerve system disorder, or a muscle problem. For the extraoral, facial asymmetry is to be noted, any pigmentation, lymph node to be noted, and TMJ should be checked. Coming to the soft tissue examination, under that floor of the mouth, oropharyngeal region, tongue, lips, soft tissue should be examined for the any of the lesions. So coming to the gingival findings, so the important one, first one is the color. So generally it is described as coral pink as a normal gingival health, but in Asian population we can't see this coral type of pink. So we can write it as pinkish in nature. So there are three main factors that determine the color of gingiva, that is vascular supply, thickness and degree of keratinization, presence of pigment containing cells. So you can write down the normal as pinkish, and for different conditions you can the color can be changed. That is, acute gingivitis bright red, chronic gingivitis that is bluish red, and traumatic occlusion small crescent shaped bluish red area in the margin of gingiva. Gingival fibrosis, it is lighter in color, marked pallor of gingiva, pernicious anemia. And for pale pink, you can write for the pallor of gingiva, pale pink, and also for inflamed condition like bright red or reddish pink, you can write. And for the established type of gingiva, stages of gingivitis, you can write as bluish. And also for the pigmentation, for the normal pinkish with brown with melanin pigmentation can be seen some of the patients. So coming to the consistency, that is the second most important like findings should be noted. That is consistency. It is firm and resilient with the exception of mobile free margin, tightly bound to underlying bone. So if there is any like gingivitis condition, it will be soft and edematous, and it will be indifferent in case of the chronic gingivitis and acute form of gingivitis. So mostly we come across with this chronic type of gingivitis with soggy puffiness, that pits on fissure, that is and marked softness and friability. Then in case of fibrotic changes and gingival enlargement, you can see firm leathery consistency. It is due to fibrosis and epithelial proliferation. And acute forms of gingivitis with diffuse puffiness and softness can be seen in case of acute inflammatory origin. And sloughing with grayish flake like and that is because of the pseudomembrane in case of like NUC, that is acute necrotizing ulcerative gingivitis. And vesicle formation also can be seen in that type of acute type of gingivitis. It is intracellular edema with degeneration of nucleus and cytoplasm and rupture of cell wall. Coming to the contour and form, it will be it mainly depends on shape of teeth and alignment and the arch, location and size of the area of the proximal contact, and dimension of the facial and lingual embrasures. It will be in normal gingiva, it will be scalloped and knife edged. So if there is any disease condition, and it mainly depends on, as I said, these are the factors that determine the contour and form. So usually when there is disease condition, it will be rolled out margins with blunt interdental papilla. And gingival contour changes with the gingival enlargement also. So, and also in traumatic, some other conditions like trauma from occlusion, you can see that Stillman's cleft, as the picture shows, this is the apostrophe shaped um, gingival contour, that is Stillman's cleft, and McCall's festoon, that is a thickened band like gingival margin. So this is called as McCall's festoon. So these are the different like like now findings under contour and form. So coming to the size, the sum total bulk of cellular and intercellular elements and their vascular supply determine the size of gingiva. So if there is gingivitis, there will be increased amount of gingival enlargement, and gingival hyperplasia can be seen. and it is decreased in gingival atrophy and recession, it will be reduced. Alteration in size is a common feature of gingival disease. So for case of gingival enlargement, you have to grade it according to Buckingham classification, that is papillary enlargement, papillary and marginal, and also it is more than two-third or 3/4 of the tooth surface, that is grade 3. And also it can be of different types, as we said, that is inflammatory, there fibrotic. More type of fibrotic will be drug induced, idiopathic and combined, and those associated with a systemic disease, that is condition mostly we come across with the pregnancy, like gel advent, like puberty, vitamin C deficiency, and with the systemic diseases, there is leukemia, granulomatous disease, and also neoplastic enlargement, benign tumors and malignant tumors, and then folds enlargement. Coming to the surface texture, a textured surface similar to orange peel appearance referred to as stippling. Stippling is best viewed by drying the gingiva. Loss of surface stippling is an early sign of gingivitis. So I would like to add upon that, like we cannot see in every individual in healthy gingiva, might you might come across with the absence of stippling also. So that is not a disease condition. So for that you can write it down as absence of stippling, not as loss of stippling. So when you write as loss of stippling, it should be like lost by the disease. So that can be noted as an early sign of gingivitis. Okay. So usually smooth and shiny will be the surface with the exudative type of change with the pocket depth, and firm and nodular will be the under fibrotic changes. So coming to the position, as you know, gingival margin, if it is coming down, it might be exposing the tooth surface, that is called the gingival recession. So it is refers to the level at which gingival margin attached to the tooth. So this is a Miller's classification of gingival recession, and now we are following 2017 gingival recession classification, recession type 1, 2, and 3. So this recession can be classified as visible, hidden, apparent, and actual. So visible, that is the area what we are seeing, and hidden, that is under the gingival area. So apparent, actual position will be from is the level of epithelial attachment to the tooth, and apparent will be the is the level of crust of gingival margin. So that is what we have seen, that is apparent. Actual will be from here to here. This is actual, and apparent only will be till the crust of gingival margin. Coming to the bleeding on probing, the insertion of a probe to the bottom of the pocket elicits bleeding in the gingiva if the gingiva is inflamed and the pocket epithelium is atrophied or ulcerated. So it is an early sign than color changes. Depending on the severity of inflammation, so it will be seen in early lesion. So it is the earliest sign than color changes. So that is bleeding on probing. So depending on the severity, it vary from a tenuous red line along gingival sulcus to a profuse bleeding. So after the successful treatment, the bleeding on probing get stopped. So to test after probing, to test for bleeding after probing, the probe is carefully introduced to the bottom of the pocket and gently moved along the pocket wall. So as the picture shows, it should be inserted inside the papilla, inside the sulcus. So it should wait for at least 30 to 60 seconds for the bleeding. Then coming to the separation, what is separation? That is the like accumulation of purulent exudate. There is the presence of an abundant number of uh, neutrophils in the gingival fluid transforms it into a purulent exudate. So there is what is called separation. Clinically, you can use the presence of pus in a periodontal pocket is determined by placing the ball of the index finger along the lateral aspect of margin gingiva and applying pressure in a rolling motion toward the crown can be. And sometimes it does not provide any diagnostic or prognostic information. However, X-rays on digital pressure speaks of pocket and nature of inflammatory changes in the pocket wall. So as the picture shows, the finger, with the digital pressure, you can squeeze out and this pus will come out. So there is a pus X-ray. Okay. So coming to the frenal attachment should be noted in case of finding the pain is important in periodontics because it might lead to gingiva recession and also improper oral hygiene maintenance. So depending on the attachment of fibers, it has been classified into classic until 1974. There is mucosal type, it is attached to mucosa, so it doesn't have much effect on periodontium. Then coming to the gingiva, gingiva also doesn't have much effect on periodontium, only visible the aesthetics part. And papillary will have some amount of effect on periodontium, whereas papillary penetrating will have more effect on periodontium as it leads to gingiva recession and pocket depth, bone loss, and also with aesthetical problem and also midline diastema. So this is the test, that is tension test can be used, can be applied to find out the frenum pull along the area. So that is should be applied to lip in outward, downward, upward motion. So retraction of the mucosal margin, then pocket formation, which leads to pocket formation and initiation of an inflammatory process. So which leads to proliferation of adjunctional epithelium and renewed extension of the pathological process. So this is the pathogenesis to get effect on periodontium. So next one is width of attached gingiva. So width of attached gingiva to be noted. It is very important because the attached gingiva is the only gingiva that is attached to the periosteum. So it has to be noted. So it is the distance between mucogingival junction and the projection on the external surface of the bottom of the gingival sulcus or periodontal pocket. So it has to be calculated. That is, this is the total width of attached gingiva from gingival margin to the mucogingival junction, and you have to probe it and see the sulcus depth. So this is, you can probe it and see the sulcus depth, and then can be subtracted from the total width of gingiva, then you will get the width of attached gingiva. See, this is how we can measure the by using periodontal probe. So you have measured the total width and, till the mucogingival junction, then you have probed it inside the sulcus depth, and then you have subtracted it from the total width. So you will get. Then one more method is the tension test. That is, you can just retract the lip outward and upward, and it will be moved. So the alveolar mucosa can be differentiated from the attached gingiva. Then coming to the roll test can be used. So you can use the probe to just roll it over the gingiva. Then this will differentiate the attached gingiva from alveolar mucosa. So the normal values ranges are in maxilla it will be 3.5 mm to 4.5 mm, and for mandible it is 3.3 to 3.9 mm. It is least in first premolar region, that is maxilla 1.9 mm and mandible 1.8 mm. Width of attached gingiva. So coming to the most important part of periodontics, that is the pocket measurement. So there are two types of pockets, that is histological depth or the clinical probing depth. So histological probing depth is the actual depth. It is the distance between the gingival margin to the base of the pocket. So it will be measuring the entire amount of coronal end of junctional epithelium till the coronal end of junctional epithelium till the attachment it will be measuring. So for the clinical or probing depth, there is a distance to which the probe get penetrated. So as you can see that how much it gets penetrated, that is the clinical probing depth. So probing technique is called walking the probe, that is probe is inserted parallel to the long axis of the tooth and walked circumferentially around each surface of the tooth to detect the deepest penetration. For concavities, you can just obliquely place and find out the depth of the intra-bony defects. And otherwise the technique of probing is called the walking the probe, that is stepping into the each area circumferentially, so you will be able to detect the deeper areas and defects. So this is what vertical insertion of the probe may not detect interdental spaces, as we said. So that is like obliquely placing, you might find out that with the tactile sensitivity you will find out the depth of the craters. So coming to clinical attachment level, so determination of clinical attachment level. So first we want to know what is pocket depth and what is the difference between pocket depth and the clinical attachment level. So pocket is the distance from the base of the pocket and the gingival margin. Then you can see that in the picture that this is the pocket depth, that is it's from the gingival margin to the base of the pocket, whereas clinical attachment level, it is the distance between the base of the pocket and a fixed point on the crown such as CEJ. So this has been marked as the clinical attachment level. So then the pocket change from time to time even in untreated periodontal disease also, owing to changes in the position of gingival margin. Therefore, it may be unrelated to the existing attachment of tooth. So it might get like can be coronal migration of gingival margin also, and also like apical migration of gingival margin also from time to time period in untreated cases also. That is why it doesn't indicate the severity of periodontal diseases. Whereas clinical attachment level, it is fixed. It is a fixed point on the crown is taken as one of the point. So changes in the level of attachment can be due only to gain or loss of attachment and afford a better indication of the degree of periodontal destruction. So which clinical attachment level determines the severity of periodontal diseases. So how to determine the level of attachment, that is clinical attachment level, how to determine. So when the gingival margin is located on the anatomic crown, the level of attachment is determined by subtracting from the depth of the pocket the distance from the gingival margin to the cemento-enamel junction. So if both are the same, the loss of attachment will be zero. So when the gingival margin coincides with the cemento-enamel junction, the loss of attachment will be equal to the pocket depth. So when the gingival margin is located apical to cemento-enamel junction, the loss of attachment will be greater than the pocket depth, and therefore the distance between cemento-enamel junction and gingival margin should be added to pocket depth. So in the diagram you can see that here the gingival margin at the CEJ, so that it will be equal, the pocket depth and the clinical attachment level will be equal, that is 6 mm. Okay, here you can see that there is coronal migration of gingival margin, so it is above CJ. Okay, and if it is 3 mm above CJ and the pocket depth is 6 mm, then the clinical attachment level will be 9 mm. Okay, so that is probing depth will be more than the clinical attachment level. So that is the this one. And next one, if there is apical migration of gingival margin, you can see the pocket depth will be minimal. So than the clinical attachment level. Clinical attachment level you have to measure from CEJ till the base of the pocket. So this has to be added. So the pocket depth plus the area of recession should be added for finding the clinical attachment level. So this will be continued as the second part. Thank you.